Okay, so welcome to Pharmacology Review. This is new for us. You've got me and Chris here to go over all of our drugs, and this is what we would typically have done in your jump bag groups or small teams. So if you happen to print off the drug sheet from Sakai, you can follow along with us. The main thing here is you have to memorize the doses. We're going to go over some of this information and then actually show you how we administer the different things. So we're going to start first. The most important thing is the 5 rights of drug administration.
What are the 5 rights of drug administration?
So you have to have the right patient. What do we mean by that? In EMS, that's pretty straightforward, right? You have one patient, that's the right patient. If you're working in a hospital setting, of course, you always have to make sure that you have the right patient. So the right drug. So we got to make sure that we are selecting the right drug for the problem and that we have actually picked up and are using and delivering the right drug. So that's another thing we got to be careful of. Another thing is that we got to make sure that we're giving the right dose. So it's very important to make sure that you know your doses and also to always check your concentrations on drugs. So for example, when we start talking about albuterol and drawing up albuterol, we'll talk about concentration and why that's important, that you know how to calculate that and what it is. Next, you got to have the right route. So we wouldn't want to give something that is supposed to be inhaled, give it orally.
Rectally.
We wouldn't want to give it rectally, right, exactly. And the right time. So there's kind of 2 things with right time, right? So you want to make sure that the expiration date on the drug is current, that it hasn't expired. Particularly if you're helping someone use their own medications. And by the way, you can only assist someone with their medications if they are within your state protocol for your scope of practice. So if someone said, can you help me with my insulin, you would not be able to do that. The other thing is that you want to make sure that right time is certain drugs you can give every so often. So let's say every 5 minutes. So you want to make sure that that time interval is passed before you give that drug. All right, so you got to memorize those 5 rights.
There's a great mnemonic, Doctor Department. You know who came up with that, Lynn?
Yes.
Who came up with it?
I think it was me. You think it was you?
I think it was me.
Oh, well,
I think
we're just both geniuses.
We're just both geniuses. I could have sworn I came up with that.
I thought it was me.
Hey, you put it in the PowerPoint slide. I thought I made it up. So it's DRDPT, dose, route, drug, patient time.
Yeah, there we
Doctor
go.
Department.
Okay.
Well, why don't we practice our doctor departments on our drugs?
Okay.
Okay. Well, so the first one we got is Acetaminophen, pain reliever. Okay. So the dose you all should memorize is Acetaminophen is used for pain and fever, and we use it for adults as 1 gram. That's also for those of you who like bigger numbers, 1,000 milligrams. They're equivalent. Okay. Our pediatric dose is 10 milligrams per kilogram. On your sheet, it says 10 to 15. That's a little, if you want to be a super knowledgeable person, you can do that, but I would just memorize 10 milligrams per kilogram. We do not do repeat doses. How Tylenol works is it does black magic and just reduces pain and fever through body mechanisms, all right? The contraindications, this is high yield. It cannot be used if patients have coexisting liver disease. Okay, so unfortunately, some people try to end their life with Tylenol overdose, and how that ends people's life is it kind of induces liver failure. And so if you can remember that, that will help you remember that Tylenol shouldn't be used in liver disease. And it is given orally, which means that they can't swallow, they can't protect their airway, you should not give it to them.
Okay. So let's say someone has overdosed on acetaminophen.
Yeah, did you like that segue?
Yeah, that was perfect. So we're going to give them some activated charcoal. Now, activated charcoal is kind of going out of favor a little bit in EMS. A lot of places have taken out of their protocol. This happens to be a powder form of activated charcoal that has to be mixed with water. It also comes as sort of a sludge in what looks like a big toothpaste tube. And charcoal is indicated for someone who has ingested some kind of a substance. And it has to be delivered within 1 hour of ingestion for it to even be effective. So the way charcoal works is it actually adsorbs. Note that's ADSORBS, adsorbs. It doesn't actually absorb it, but rather It binds to the whatever toxin is in the body and moves it through the intestinal system. Some really important things with charcoal. If you've ever seen it, it's really gross. It's this sort of black sludge, and if you can imagine drinking a cup of black sludge, you would probably want to vomit also. So our biggest risk for using activated charcoal is the risk that your patient vomits and then aspirates this thick, gooey black stuff into their lungs. We cannot give this, therefore, to anybody who has altered mental status, unable to swallow, okay, and cannot maintain their airway. Another thing is, I mentioned it's not all toxic substances, because if someone has ingested a caustic substance such as hydrocarbons or bleach or something
acid,
like that, then if they throw up, what happens? Well, all that bad stuff comes back up their esophagus and does more damage on the way up. And so we do not give this for caustic substances. So because of its inherent nature, some of the side effects are diarrhea, darkening of stool, and vomiting. And again, this is a lot of places or EMS services are really debating whether this is even a valuable drug to use. But as of right now, it's in the state scope of practice. The adult dose is 50 grams. This is a 25-gram bottle of powder here. And the pediatric dose is 1 gram per kilogram up to 25 grams. So this would be a full dose of this would be pediatric dose. Anything you want to add?
If I'm a 30 kilogram pediatric child, how much would you give me?
Well, that would be 1 gram per kilogram, and you're 30 kilograms.
Yeah.
I'd be giving you 30 grams.
Up to 25 grams? Do I stop at 25? Right?
Yeah.
So the max peds dose, 25 grams.
There you go. And pediatrics, so that's kind of hard to say. So pediatrics, one, how do you know if a kid is pediatric? Well, it's not so much age anymore as it is till puberty. So I would say if that person appears to be going through puberty, then I would treat them as an adult.
So regardless of their weight, you would give 50 grams.
That's correct.
But under puberty, max 25, 1 grams per kilogram.
Correct.
Great.
All right. So moving on to...
I'm having a little bit of trouble breathing.
You
Yeah,
are?
yeah.
Well, we've got some albuterol here for you.
I'll tell you about albuterol.
Okay.
One of my favorite drugs on our formulary on this sheet of paper I have. Albuterol is such a good drug. It is a beta-2 agonist. That's high yield. That's on like every test. Beta-2 agonist. So do you remember the difference between alpha, beta 1s, and beta 2s? Well, of course, alphas vasoconstrict because it's a little lasso around the blood vessel. Beta, 1 heart, 2 lungs. So 1 heart, beta 1s increase heart rate, beta 2s open up your lungs, bronchodilate, you could say. So that's how this works. You need to know that.
So Chris, this just says this is saline.
Oh, well, shit. We should have gotten real albuterol, but it's okay. So we are using simulated albuterol, which is saline in this reality of ours. So
It's a lot cheaper, folks.
It's a lot cheaper, folks. So how it works is there's multiple ways to give it, which is why I love it. Okay, we can use a small volume nebulizer, Lynn. We can use a small volume nebulizer. Would you like to start assembling this for me as I keep talking? I'll give you all the parts you need.
Okay, great.
Small volume nebulizer. So how we assemble this, and this is particularly high yield for you to remember, is you always need your little corrugated tubing, a T-piece, and it only goes on one way, folks, okay? You could really screw up if you tried, but we don't want you to try to screw up. We should succeed. So it goes on the end as such, and then we put our mouthpiece on the other end, opposite the corrugated tubing, and then you just smack that bad boy right onto the nebulizer. Now, you may ask, how the hell does this nebulize a medication? Well, that's when we would hook it up to oxygen. So,
Okay, but you haven't put the med in there.
I know,
Chris.
I haven't put the med in there yet because we're going to do that in a second. So
Okay.
this would be hooked up to oxygen. So then what we do is we take this off and we're going to pretend to put saline in there. And you know how much I'm going to give?
Why don't you actually put it in there?
Oh, let's do that. I'm going to give 2.5 to 5 milligrams in 3 cc's. So when Lynn talks about concentration, that's where it'll get you. The 3 cc's isn't a dose. It's the mass of the medication dissolved in that dose. So this says, oh, what did you know? 2.5 and 3 cc's. So we're just going to put that right in there, squirt that in there, and that's all done. And then put this back on.
So Chris, now I'm going to
Yeah.
hook this up to the oxygen tank.
Great, yeah.
And what are you going to set the flow meter at?
Oh, I think it's 6 to 8. Is that right?
That's correct.
Oh, okay.
So we're going to go 6 to 8. If you put it on a lot faster, then all your medicine is going to, lose your medicine. So the medicine in here actually gets aerosolized, and you will see like smoke coming out of the end of this blue tubing. If you set your flow rate up higher than 6, or 6 is usually good. If you set it up higher than 8, though, you'll just go through your medication and the person won't have a time to breathe it in. So once you set this up, you hand it to them. You're going to have them put their mouth over the mouthpiece and just breathe, and coach them to, each time they take a breath, to try and hold their breath so that they can hold the medication in their lungs for as long as possible. And your patient just holds this and breathes through the nebulizer. When the treatment runs out,
Yeah.
so we need to add some more. So we want to give another 2.5 milligrams in 3 cc's.
Yeah.
So Chris is going to do that while I show you. There's a couple
Blow some
ways to
money
do
away and
that.
put some more in.
If I just open this now with my oxygen running, what do you think is going to happen?
Oh, I think it's gonna.
It's going to spray in Chris's face.
Yeah, we don't want that.
So here's a way to do it. A couple of ways you can do this, but the best way is, rather than having to cut your oxygen off, you can just go ahead and clamp your tubing
Oh.
to cut off your oxygen, and then you can just pull off this part,
Oh, look at
and now
that.
you can pour it right into the top there.
Oh, well, that was so easy, Lynn. That was good pearl.
And put it back on.
Then
Let
you
go
got
of
your-
your oxygen tubing. I don't know why this isn't sticking on there. And you can give it back to the patient. So you might ask, well, if we're giving 2.5 milligrams and 3 cc's, are we supposed to put 5 milligrams and 6 cc's? My answer to that is it doesn't really matter. You can put 5 milligrams and 3 cc's, or you can put 5 milligrams and 6 cc's. It really doesn't make any difference. Here's the deal.
Here, yeah, the deal of the dose.
Yeah, what's the dose,
The
Chris?
max dose is 15 milligrams for an adult, and then the dosage and concentrations for peds is half. So the max dose in an adult for you all is 15 milligrams. Max dose in peds is 7.5. The increments of dose can be 2.5 to 5 and 3 cc's for an adult, or 1.25, which is 2.5 divided by 2, to 2.5, which is 5 divided by 2, and 3 cc's for peds. So just
Okay,
take the
now
adult dose, divide by 2. They're following me. I know they are.
All right, good.
Yeah. And then 15 for an adult, divide by 2, 7.5. So you can do that incrementalized dose up to 3 times when it runs out, which
Yeah.
can be every 5
Yeah.
minutes, but
No,
when it
could
runs
be
out.
When it runs out.
When it
Usually,
runs out.
Usually a nebulizer running at about 2.5 milligrams and 3 cc's running at about 6 liters will last about 10 minutes roughly,
Oh.
somewhere in that neighborhood. So if you're putting 2.5 milligrams into it each time,
Oh.
then you can do it how many times?
6 times.
You can do it 6 times. If
Algebra.
you're putting 5 milligrams in each time,
Oh, man.
then you can only give 3 doses.
Oh,
So
yeah.
just remember, it's 15 milligrams as your total dose.
Great.
Okay.
How it works, dilates those bronchioles. All right, so we use it for any time someone's bronchioles are constricted. So that's asthma. That could be allergic reaction. That could be COPD with wheezing. All right. Now, these drugs aren't perfect. They don't only go after beta 2. All right, they do a little beta 1 in there. And so because they act on beta 1s, they increase heart rate as a side effect. And if someone's heart rate is already elevated, that could be a contraindication. All right, so if their heart rate is over 150 or 200 in peds, 150 in adult, or they have cardiac disease such as angina, then we don't want to be giving this to them.
So, but you always got to remember, a lot of these drugs are contraindications, not necessarily written for emergency situations. So you always have to weigh the benefit versus the risk. If someone can't breathe, then they need albuterol, because the risk is that they go into respiratory failure.
Not acceptable. Yeah.
So Chris,
Yeah.
I really can't hold this because I'm really struggling to breathe, and it's really hard for me to try and coordinate all of this. So what would be another option?
Oh man. Well, I'm worried about your airway and your breathing. I could call ALS, but I could also use a non-rebreather.
And how would we do that?
Oh, great. Yeah, I love the segue. So here's a non-rebreather mask. All right. This bag, we would just take this bag right off.
Let you punch me in the face.
Yeah, I'm so sorry. Just making sure. And you know what? I would keep this still on 6 to 8 liters. It doesn't change if I'm on this mask. It doesn't change. All right, because it's hooked up to this. This is what's the 6 to 8. And then I would just put this on. All right, and then you make sure you tighten everything up. I can't, but you tighten it up, and you know what? You just spill it all over yourself. Okay. And then it would just go. It's great. Oh man. Well, shit, Lynn. I think I just went unconscious. How would you give this to me if I was unconscious?
That's a bad problem.
Yeah, it's a bad problem.
Here, folks.
Probably just call it, right?
Yeah, we just call it.
Yeah.
Heck with it. We don't know what we're doing. All right. Well, there's a bunch of pieces here. Anybody got Legos?
I love Legos.
All right. So, true story.
Yeah.
Went on a call when I was brand new medic. Actually, I was on a truck. I was still precepting. And we get to a standard asthma call out at Harris Teeter. Somebody was having trouble breathing. So we mosey on over there in the ambulance, figuring this is going to be pretty much standard, give a nebulizer treatment and move on. And when we pull up, we look out, and first responders are bagging this patient on the ground, which was a pretty scary situation. There was another medic on the call with me who was more senior than I was, and between the two of us, we had no idea how to attach a nebulizer to a BVM. By the time we got this patient in the ambulance, we were having to intubate him. He was a tough intubation. We could not get a tube in. We ended up having to put combi tube in, and about the time we got the combi tube in, he went into cardiac arrest, and this whole thing went south really fast. I can tell you after that, I got all the pieces. I made pictures of them. I used to carry a picture of how to assemble this in my pocket, because that call, to this day, I remember. The guy fortunately did survive, at least to admission. I don't know whether he ever left the hospital. So, really important skill. Last class we had, we practiced this until everybody could do it with their eyes closed, which was actually kind of fun. If you had the parts, we could do that, but unfortunately we don't. All right, so how are we going to hook this up? So we're going to need a bunch of different pieces here. The key thing is that you want to hook the actual nebulizer reservoir piece closest to the BVM.
This is high yield.
Okay?
Yeah.
So now we're going to take the blue piece, because this gives us some room to work. And we're going to attach the blue piece here. Okay. Now we need this little elbow-shaped piece, which is going to go on here. And do we have a face mask?
We did, and then I put it back up, but you know, we could get it real quick.
Yeah, let's get the face mask out. That we need.
Oh, I was like, oh, we won't need that, Liz.
All right, so
okay.
now we're going to attach that little adapter.
It doesn't need the. Doesn't.
Yeah, it does.
It's not going.
It should go. Yeah, we'll go in.
Oh, yeah,
There we go. Okay, so there we go. This is what this setup looks like. So now I can put this over the face of my patient, and I bag. Now, where does my oxygen have to be hooked up?
Oh, I think it has to be hooked up to 2 places.
That's right. So
one at 6 to 8, over here 15 to 25, where the normal BVM spout is.
So because you're trying to nebulize at the same time you want to be giving 100% oxygen, you've got to have 2 sources of oxygen to do this. All right. So again, you've got your BVM with your standard T adapter hooked to your nebulizer, your corrugated tube, then you have your T device, or your L device rather, then you have to have this little tiny mini adapter here, and then your face mask. All right, and then we would just bag our patient as we would with any other patient.
And the great thing about that adapter, Lynn, is if you have an advanced airway or an ET tube, it can go right on. So
There we go.
an endotracheal tube, a King airway, an eye gel.
So we can use this setup for any kind of blind insertion airway device, so iGel or King, and also for an ET tube.
You know, I've seen some students do it like this. Very pleasant. Why can't I do it like this, Lynn? Why don't you show them this? Why can't I do it like this?
Well, you could.
But I'd be wrong.
So it's a lot easier to manage it when you have the nebulizer closest to the air blowing out of your bag, because we want the pressure coming out of the bag to force the aerosolized liquid down into the face mask or to the tube.
That's a good point. I've also think that this would crash into the person's cheeks and face, because this is in their mouth. Their face might be running into this. So I don't like to see this when I see it.
No, it's not a good.
It's not good. It's not perfect. This is perfect. With it closer to the bead.
All right, so take a look at that and go back and review this video, because at some point when we do practical skills, you will be expected to know how to do this. Okay, all right.
But there's yet another. This is why I love Albuterol so much. It's just ripe for quizzing students on do they know how to do these skills. You can also use Albuterol as a meter dose inhaler. All right, meter dose inhalers are frequently you'll see in the outpatient setting that they'll carry around on their own. You can assist patients with their own if it's the same medicine. You have to look at the medicine. If it says something like ipratropium or something like that, that's not an EMT basic drug. So on here, I can say it says Albuterol USP, and it says 17 grams. Oh my, does that mean I'm giving 17 grams per spray?
That's the total amount.
That's the total amount, exactly. And then 200 inhalations, you can do that math. I do not want to do that math right now. Basically, you shake it up, and then puff it. And this is empty, but it would come out. Now,
so Chris, before we do that,
yeah, okay.
what am I going to instruct my patient to do?
Oh, great. I want them to have a spacer.
That would be ideal if
Yeah.
we had a spacer.
High yield.
I actually have one, but don't have it out here. At the
Damn
table.
it. Okay.
But here's what has to happen. So I'm going to shake this up, and then I'm going to tell my patient to exhale strongly, and then to wrap his mouth around the mouthpiece. We're not actually going to do that. And I'm going to tell him when I push the button to take a big inhale. So I push the button, push the albuterol, he inhales the medication, and then you want to encourage him to hold his breath for about 15 or 20 seconds or however long you can, so that the medication gets down into the lungs.
So that's the MDI, and there's even one other way to give albuterol. It's just the gift that keeps on giving. You see this in Durham, right? This is what Durham uses.
They used to. I don't think they're doing it anymore.
Well,
but you might see that someplace because it's very cheap.
This is an albuterol dropper. So these were single-use bullets. This is a dropper that can be used on multiple patients. And on here it says 5 milligrams per milliliter. I had to make sure I was reading the right number. Now, this is some chemistry 101 stuff. Remember your volume and concentration. So I want to give someone 5 milligrams. How many milliliters would I give them? 1 milliliter. All right. So I would soak up one. It's a little eyedropper. I would put this in here.
And how much is that?
This is only 0.5 milliliters. So this would actually be 2.5 milligrams.
So
can't get me, Lynn. I'm too good.
Mm-hmm.
So I put, how many milliliters did I put in there? I put in there 0.5 milliliters because it is 5 milligrams per milliliter. I put in 0.5, so it's 2.5 grams. So I can add saline 2.5 milliliters to get my 3 cc's, 2.5 milligrams and 3 cc's.
That's correct.
Make sure you understand that math.
So let me just make sure I understand it.
Yeah,
so we're gonna draw up, if I draw up to this marker in here that says 0.5 milliliters
Yes.
on the line, which means this is 2.5 milligrams
A mass.
in basically a half a milliliter of saline.
Yeah.
Okay. So if I need 3 milliliters of saline, I got to add 2.5 milliliters of saline.
Yeah.
And I can add it. These are literally saline bullets. These are 5 cc's and a pink bullet. So I would add half of this, which is 2.5 cc's in here. Now I have my 3 cc's plus I have 2.5 milligrams of medication.
But if I wanted to get 5, I would do 0.5 twice for a total of 1 milliliter. Add 2 cc's of saline, and that would be my 5 and 3.
That's correct.
Great. So make sure you understand math. Always applicable.
All right. So
Yeah.
that's
Albuterol. That's a bulky drug, let me tell you.
all right. Next up is aspirin. So aspirin is also a wonderful drug. It's been around for a long, long time. Used to be used for pain and fever for children, and that went out of favor because of a condition called Ray's syndrome. So we no longer use aspirin for, at least for children at all, period. But we do use baby aspirin for adults. Again, not for babies, for adults. Baby aspirin, this is 4 chewable baby aspirin. They come as 81 milligram tablets. And aspirin probably is your first line drug that you should be giving to someone when they complain of chest pain that you think they're having a heart attack. The reason for that is that there really are no contraindications to aspirin other than the patient has an allergy to aspirin. So you have to go to somebody who's having chest pain. One of the first things you ask them once you have had a chance to get some of your history is whether or not they have an allergy to aspirin. If they say no, get your 4 baby aspirin on board. 81 milligrams times 4 is 324 milligrams. And how do we want them to take it? We want them to chew it, right? So we don't want them to swallow it.
Yeah.
So we're going to give it to them and tell them, chew these 4 baby aspirin up. So how does baby aspirin work, Chris?
I'm glad you asked. Isn't it a blood thinner?
No.
Damn it.
A lot of people think it's a blood thinner.
Oh man.
But it's not.
Got me.
After your 4th year of med school, you'll know that.
Yeah. Oh, it's an antiplatelet.
Ah, there you go.
So sometimes we like to quiz your knowledge by asking you, how does aspirin work? And this is actually kind of important because aspirin, there's 2 ways clots form in your body. There's the platelets and the coagulation factors. And blood thinners act on the coag factors. Aspirin works on platelets. All right. And there's many drugs that work on either or. And so that's important. So this works on platelets, Lynn.
Yeah. So what happens? And you should know by now that an MI is often because a piece of plaque breaks off and the body thinks that the vessel is injured and it basically sends in platelets, and the whole coagulation cascade starts to be able to seal up that breakage or that lesion. So when that happens, imagine a little army of platelets coming along and they start piling up like a pile of ants that can't get into the anthill, right? So now all these platelets are coming and we want to stop that. So aspirin basically keeps the platelets from sticking together. So it doesn't get rid of the pile that's already there. It doesn't get rid of the clot that's already formed. But it does prevent more of the little army of platelets from glomming onto that clot and making that clot bigger. So very important that we get aspirin on right away. And even if you go to your patient and they say, well, I take an aspirin a day, and you say, well, did you take one this morning? And they say, yes, I did. Does that mean we can't give it to them? No, we go ahead, we still give it to them.
Because frequently when patients take an aspirin a day, they take 81 milligrams a day. They don't take the full 324. So it's okay to give them, on top of a daily 81, the 324.
That's correct.
Yes.
That's correct. So side effects, not really significant in the presentation of chest pain. They may have nausea, vomiting. If they are on anything like warfarin or a blood thinner agent, then it could cause bleeding. Again, what we're looking at is risk versus benefit. So just bear in mind that when you look at drugs as a whole, the contraindications are not necessarily written to EMS, and EMS will often either not have certain histories that people may have of illnesses or diseases, and they're also, we're talking about giving these meds in an emergency situation. So some of the contraindications are definite, but some of them are more considerations to think about. So that's aspirin. That should get on board first with a patient with chest pain.
And I'm sure you mentioned this, but it should be chewed.
Yes, we talked about that.
I just want to make sure.
Yeah.
That's important to know. Well, let me talk about diphenhydramine. It's allergy season out there. My nose is running, and it's maybe corona, or maybe it's pollen.
If it's corona, we're all screwed.
Yeah. No, I'm actually not having allergy symptoms. However, I'm getting prepared. Okay, so how does diphenhydramine work? Well, diphenhydramine is an antihistamine. Histamine is kind of your allergic chemical mediator in your body. And so if we block that, knock allergic reactions out. We give 25 to 50 milligrams for an adult and 1 milligram per kilogram in kids. We use it for allergies, urticaria. You can use it for wheezing from an allergic reaction. But if someone is only having an asthma attack and no other signs of an allergic reaction, we wouldn't give it. And if someone's having anaphylaxis, this is not the first line medicine, but it's something you can consider later. And we'll talk about the first line medicine in a second. But this is basically given PO, and frequently the side effects would be sedation and thickening of some secretions. Lower yield. Maybe you recognize sedation if you've ever taken it before. My parents would give this to me before flights to sedate me.
You mean they drugged you, Chris?
Yeah, as a kid.
Yeah.
It worked, yeah.
Benadryl's a good it's a good sleeping aid.
Yeah.
You can't sleep. A lot of doctors just take Benadryl because it basically has no side effects. All right, so here's one thing that I always I see patients students sometimes struggle with, and that is we give you a scenario with someone who's having a really severe allergic reaction, they're anaphylaxis, and you've done your epi, you've done all the things you need to do, and then you go to give them diphenhydramine, and the dose is 25 to 50 milligrams.
Yeah.
And so you'll say to your proctors, they'll say, well, what's the dose you're going to give? And they'll say, well, 25 to 50. And so my response is, well, you're the provider. You can't give 25 to 50. You have to choose one or the other. So you can't give your patient a range. You have to pick one. So some students say, okay, I'll give 25. And so then I look at them and I say, you have someone who is in anaphylaxis, probably one of the worst allergic reactions there possibly is. If you're only giving them 25, then who on earth would you give 50 to? Okay, so if you've got someone that you're giving diphenhydramine because it's a follow-up drug after you've treated with other drugs for anaphylaxis, you want to go with 50 milligrams. If you have someone who's just got some cutaneous findings from allergic reaction, a little rash, they don't have respiratory involvement, but they're just uncomfortable, they're itching, go with the 25. If you're working with the elderly, go with 25. I had an elderly patient once, we used to give it IV, but I gave her the whole 50, and my student who was riding with me thought I killed her because she immediately passed out and fell asleep. I was, she's asleep and now she's fine. But I realized after that, maybe with the older population, we should go a little slower. So anyway, 50 for anaphylaxis. All right?
Yeah, great.
Okay. What's up? Speaking of anaphylaxis.
Yeah.
Epi.
Very pertinent.
That was great, Chris.
Yeah. That was not good.
Epi.
Yeah. Tell us about Epi, Lynn.
Okay, so you get a call. Patient respiratory distress, severe respiratory distress, and you arrive on scene and you find out that this patient has an allergy to peanuts, was exposed to peanuts, and is now presenting with signs and symptoms of anaphylaxis. Now, we haven't covered that yet. We're covering that this coming week when we do allergy, but believe me when I tell you that someone can go from perfectly healthy and normal and on death's door within minutes with severe anaphylactic reactions. So it's very, very important that you quickly evaluate your patient and treat them immediately. Epi is the miracle drug to treat those patients with. Forget about diphenhydramine, forget about albuterol for right now. We're going to come back to that. They need epi. So there are a couple ways you can give epi. One is with an EpiPen. EpiPens are made for adults and also for peds. The adult EpiPen is 0.3 milligrams, so 0.3 milligrams. The pediatric EpiPen is 0.15 milligrams. And we're going to talk about that dose in a minute because we're going to show you another way that EMTs can now deliver epinephrine. So if you're using an EpiPen, okay, what are the contraindications to epi in the context of anaphylaxis? Zero. All right, they're either going to die or you're going to give them epi. The indications are an anaphylactic reaction with at least 2 body systems involved, and those are most commonly our respiratory system where they can't breathe, the bronchioles close down, their airway swells, they may have, their lips may swell, their tongue may swell, they also may have cutaneous symptoms with hives all over their body, they may have GI symptoms, they may have gastric distress, and they also can have, it can be a vasodilator when someone ingests something that they're allergic to, and so their blood pressure may drop quite low. But they have to have 2 symptoms. So the first thing we want to do is we get our EpiPen out. We got to make sure, 5 rights?
5 rights, okay. Doctor department.
So let's assume that this thing is in date. It's good to go. And we're going to inject this into the lateral portion of the thigh, on the outside of the thigh, between the hip and the knee. So I'm going to take this. Chris is going to stand up.
Oh, okay.
Yes. Mm-hmm. So the first thing I'm going to do is pull off the blue cap. Okay.
Safety.
Now, don't hold your EpiPen like you're, going to stab somebody because I've had people who have mistakenly held the EpiPen this way, and what comes out of this end, the orange end, is a big honking needle. And if you hold it this way and inject it, the needle will now come through your thumb and be sticking to your hand. So we never want to put our thumb over the end of an EpiPen. So we're going to hold it like this. I'm going to actually do it left-handed since I'm on this side. I'm going to take it, I'm going to put it against the thigh, I'm going to push it in. You're going to hear a click maybe. And I'm going to hold it for 10 seconds. Although some protocols say you don't need to do that anymore. And then I'm going to pull it straight out. Can I put this through jeans? Yes, I can.
Big needle.
It's a big needle. And if we were in class, we would show you an interesting trick where if you actually open up these EpiPens, you would be amazed. This is just a trainer, but on a live EpiPen, when you open it up, you will actually see a syringe in there with basically, surprise, 3 doses of epi. So
you're telling me those drug companies put more epi in there for a single use?
Yes. So if you're ever in the woods and you cut the casing open, there's a syringe in there, and there's actually a stopper on it. And they put a syringe in there with a stopper so that when you inject it, it will only inject the 0.3 milligrams. But there's actually a full milligram of epi inside the syringe that's in these EpiPens. All right, so
sometimes in EMT class we also do live demonstrations of live auto-injectors.
We do? Oh yes, we do.
Yeah, we
won't say who.
Yeah. All right, now we're going to.
Now, I did forget something.
Oh.
Once I injected it into your thigh.
Yeah, you didn't give me my massage.
I didn't give you your leg massage. So ideally, I would massage the skin around the area where I injected it. And why would I do that? Well, this is an intramuscular injection. So it is absorbing into the blood vessels within the muscle, and if we can move the liquid around that we've just injected over a greater surface area of that muscle, then we get faster absorption. So we can rub that area for a few seconds after we inject the epi.
Great. And how it works? It's a alpha-1, beta-1, and beta-2 agonist. So it constricts the blood vessels, which you'll learn for anaphylaxis is everything is dilated. It speeds up the heart to improve blood pressure and opens up those airways to improve bronchoconstriction. And we will show you in a separate video how to draw it up as a needle and through an ampule and a vial for a separate video.
For injection in the deltoid.
In the deltoid.
Yeah. Okay.
Yep. All right.
So I think we've covered everything.
And that is part 1.
For part 1.
Yeah, for part 1.
Right.
Yeah.
Oh, we didn't say? We didn't do the